My name's Alison Beasley. My role has changed recently. I'm now the lead nurse for district nursing and long-term conditions. But in my heart, I'm a tissue viability nurse specialist, and I've been a tissue viability nurse specialist for 25 years. Okay, so I work in Oxley's NHS Foundation Trust. It's in South East London. I cover Greenwich and Bexley. We have a complex wound care team that involves a podiatrist as well as 5 TVN, so we're quite fortunate. And we have 5 community-based complex wound care clinics, which are all nurse-led, along with our podiatry colleagues, of course. So I'm going to talk to you, first of all, about wound bed prep. And I know you've done a little bit about assessment this morning, or quite a lot about assessment this morning, I think. And this is sort of adding to that and talking about how we prepare our wound bed and identify the causes that are stopping wounds from healing before we can move on and actually help that wound to heal. And I think it's just remembering that this is all part of your assessment. And in the preparation, you need to be thoughtful, really, that you're moving from different stages of wound healing and along that wound healing track. And you might need to use different components of local wound care all at different stages along that track. And I think it's just being aware of that. So I know you've talked about times this morning, is that right? So you know all about that. So I won't dwell on that one. But I am going to show you a few slides about tissue. So here we have, this is a DVT, post-DVT, the one on the left. So really necrotic tissue, non-viable tissue. We know that that's not going to go on to heal unless you can actually remove that. The other one is like 100% slough covering the wound bed. You can't actually see what the wound bed's what's going on with that wound bed, how deep it is, or what's happening because of all the slough sitting there. So it's identifying that. Now that we have our community sequence where we have to assess all wounds or reassess all wounds within 4 weeks if they're failing to heal, then it's really important that you use the TIMES and document, even if you haven't got any infection or necrotic tissue, document that everything's looking healthy, and in that way you can look back and clarify exactly when something did start to deteriorate. So infection, you know the I stands for infection. I won't go into that, I'll show you the photos, they're more interesting, aren't they? So infection, so the inflammation of the toes, or cellulitis you can see on this foot, and that must be incredibly painful. You're not going to be able to do anything very much to that until you've treated it with antibiotics. The one on the right is a critically colonised wound, where again you're going to need to clean it up and really get rid of the biofilm before you can actually encourage that wound to start healing. M for moisture, you know that. And here we have a very, very dry wound that really is not going to epithelialise unless you provide some moisture into that wound. And again, the opposite, where a very, very wet and soggy foot, which is never going to heal while you have all that macerated tissue around it. And again, the edge, non-advancing or undermined. We've got a picture here of a diabetic foot. And this is where we use our podiatry colleagues to use their scalpel skills and get rid of all that callus, because you know that won't epithelialise until that callus is gone. And the wound on the right is like a senescent, old senile cells sitting around on a wound that's been around for a long time, not been treated particularly well, certainly not with moist wound healing, and the edge is just static, it's not moving anywhere. So really, it's really encouraging it's really identifying the cause as to what's delaying your wound healing. And the TIMES helps that. And S, the new S for surrounding skin. So here again we have sort of a bit of a macerated wound and some hyperkeratosis there that we really, really need to get rid of before you can actually see what's going on under there. There might be ulcers under there. You don't know what's going on. There might be some eczema. You really don't know until you get rid of that dead tissue. So here we have a definition of debridement, because I think what you'll find is that the TIMES, in each part of that, we can actually use debridement to improve the wound bed. So here you've got a definition. So we can use debridement throughout TIMES framework. So that, for example, the T is reducing or removing the non-viable tissue. So you might want to do that. And I'm going to go on to talk about the different methods of debridement and how we might do that. But if you think about the tissue, you want to remove that dead non-viable tissue. Because if you've got dead tissue, you can't make things come back to life, I'm afraid. If something's dead, then we need to remove it and get rid of it. So once you've removed it, that actually facilitates better assessment. For infection, we might want to reduce the bioburden, and that might be through using systemic antibiotics or, nearly dropped all these, using systemic antibiotics or antimicrobials, but it also might be using debridement to get rid of the actual biofilm itself, mechanical debridement. And then we have, sorry, excuse me, excessive moisture or very dry wounds. And we might want to get rid of the macerated tissue that's been caused by the exudate and get rid of odour and the MMPs and things that actually surround a large amount of exudate. E, the edge, so we want to reduce the number of senescent cells. We want to really encourage the number of cells that are healthy and that are going to promote granulation and epithelialization. So we want to get rid of the ones that aren't doing anything. And for the surrounding skin, then it's debridement really of all that scaly tissue that's just sitting there on the surface in the way of you being able to assess that wound fully and being a focus for cellulitis and infection. Because if there's something just sitting on the surface of the skin and it's dead, you want to remove it to stop that focus for infection. So what do we need to ask before we start debridement? And we do have, Wounds UK produced a best practice, I think it's a best practice or it's a guidance on debridement, which you can find if you look it up on one of the search engines. But that contains the debridement decision pathway, and within that it has some trigger questions that you need to ask. So, do I actually need to accelerate debridement? Do you actually need to debride something? You know, why are you doing it? If you think about those elderly patients, little frail old ladies who have a pressure ulcer on their heel, it might be a really dry necrotic plaque on their heel. Do you really need to debride that and create some sort of large festering pressure ulcer that actually is very difficult for them to cope with? Or could you leave them with just a dry plaque on their foot and allow that to continue? So sometimes you don't actually need to debride. So really think about, do I need to be doing this? If you think, yes, I do need to be doing this because it's going to help improve the wound bed, if you're thinking that, then think about what the risks are. So the risk to the patient, the risk to you, to your accountability, your NMC code of conduct, you need to ensure that you're competent in what you're doing. So is it too risky for you to actually do that, or is it too risky for the patient to undergo that type of debridement? So identify the risks and think about, weigh them up. And then what are the expected outcomes? Do you expect the wound to go on to heal once you've done this? Or will there be a need for further types of debridement or further types of treatment? So really weigh it up, and you can only really do this in discussion with both the patient but also the MDT and family carers, etc. So it needs to be a big holistic discussion about how you're going to do it and what you're going to do and what you expect to happen once you've done it. So once you've gone through all those, you need to think about, okay, how am I going to go about doing this? What are my options? And am I going to be able to do this myself, or am I going to have to ask somebody else to do it? So is it a simple process of debridement, or is it something much more complicated and something that I will have to refer to a specialist for? But really, the most vital thing really is only commence debridement if you're competent in the chosen method. So if you don't feel that you're competent, then don't do it. and make sure you know what you're doing and why you're doing it, and document that. Always vitally important. So here, I know you can't see that very well, but this is the decision pathway, and this will help you through thinking about all those trigger questions. But it does say consult with the MDT, discuss with the patient, refer as necessary. So there are lots of different methods of debridement, and there isn't one type of debridement that's right for everybody. And there are good reasons to do some types of debridement at one point and other types along the way. So really it's thinking about your patient, as we said before, and what's right for them and what's right for the stage that you have your wound out as well. Excuse me. Okay, so we'll start with surgical sharp debridement. Now this is done by surgeons, so therefore it's very costly, and would have to be done in hospital under anaesthetic, therefore very costly to the patient as well, having to undergo an anaesthetic. It is very effective. It gets rid of the non-viable tissue. They actually debride the wound down so it becomes an acute wound, so they do get rid of some of the viable tissue as well, but it's very selective, very immediate, all done very quickly. Does require a period of time in hospital, and it doesn't always work. I've had a young patient who went in before he came to see us. This is a few years ago now, but he'd had surgical debridement. 2 weeks later he was back in my clinic with a really sloughy plaque because they'd debrided the wound, but they hadn't addressed the underlying cause, and so the wound had just continued to do what it had already always done and produce lots and lots of slough. So it doesn't always work, and it can be very costly. Not saying that it's not right for some patients. And then conservative sharp debridement. Some of you will be able to sharp debride. Can anybody do sharp debridement here? Anybody been on a course? No? Okay. There are courses around, accredited courses, to be able to do sharp debridement, but that would have to be in discussion with your TVNs. It's usually the TVNs and podiatrists that are doing sharp debridement. Certainly podiatrists are the ones that are always wielding their scalpels. So if you want to watch some of it being done, they always talk to a podiatrist. And this involves the removal of non-viable tissue, so just above the viable tissue level. So there is the risk that you will leave some non-viable tissue behind. And it also might mean that you have to use dressings to soften up that tissue. If you've got really thick, hard slough that you can't get rid of, you need to soften it up a little bit before you start trying to remove it with your scalpel. What we've found recently with some of our sickle cell patients that have very, very painful leg ulcers is that we put some Emler ointment sometimes around the edge of the ulcer just to numb it, leave it in place for 15 minutes, and then they will allow you to do some sharp debridement. I've got one chap who he really just won't let me do anything to his wound, not even wipe it with a piece of gauze. He won't let me do anything. So we decided to use this, and now I can actually get rid of some of the slough. So every week we do this process, and we're gradually improving the wound. It's gradually getting better. But we just know if we don't remove that slough, it's not going to go on to heal. Larvae therapy. Who's used maggots? Anybody used maggots? No, nobody. Yeah, a few. Jolly good. Is that in the community or in hospital? In the community. They're much easier to use nowadays, aren't they, than they used to be when we used to have to sleep them down and they'd all escape. They come in tea bags, exactly, yeah. Yeah, they do. So they're much easier to use. They're much more acceptable to the patient, I think. I think it's much easier to accept if you know that they're all contained within a tea bag rather than if you're sort of pouring them onto the wound and looking at them wriggling around. So again, that is fairly costly. It's obviously down to the patient. It involves a lot of discussion with the patient. And then autolytic debridement. I would imagine that most of you have used autolytic debridement because that's the involvement of moist wound dressings to soften up and de-slough and debride. It can be slow. I think we all know it can be slow, which is why we need to think of other ways of debridement sometimes. But, you know, eventually you might get there. you do run the risk of maceration, pain, discomfort, prolonging wound healing with all the risks that entails. So it's not always the right thing. And then we have physical or mechanical debridement. And traditionally this has been wet to dry method that they do in the USA sometimes, I think. They put wet gauze on a wound and then let it dry out. So for however long it takes to dry out, and then they rip it off. So it's very, very painful. So it's not something that we would recommend in the UK, certainly not. I'm sure it's effective, but I don't think I would like to put any of my patients through that. I really wouldn't. So we do have another method of mechanical debridement, and that's using the physical debridement cloths. So I've just got a little question for you. How many of you currently debride wounds in your day-to-day practice? So on a regular basis, you'll be debriding wounds. How many of you? All you community nurses out there? Yes? Okay, so not loads of you. And what prevents you? So those of you that don't do that, what prevents you from doing that? Training. Right, yes. Anything else? What did you say? Somebody said something down here? No? Anything else that prevents you from doing it? Time it takes to learn how to do something, getting your hands on the equipment, I suppose. So the pre-moistened debridement cloths are, well, the chaps on the Medi stand will tell you much more about what's within them, but feel free to open them and have a look and use them on your skin. You'll see what they're like. They're actually a cloth that has tiny little, tell me if I'm wrong, they have tiny little hooks on there that you can't see, microscopic hooks, that when you circulate the cloth on the skin, it will hook onto the dead debris and the dead tissue and remove it. So it helps prepare, sorry, calm down. It helps prepare the wound for healing by gently removing any surface debris and slough and biofilms, and it helps to improve the wound margins. It also can help soften and remove hyperkeratosis, and I'm going to go through and show you some photographs so that you can see how we've actually used it in our practice. They also are very, very simple to use, and it means that the patients can use them themselves. So we give them to the patients to continue care so they can carry on the care that we've started. So we'll whiz through here. Where and when to use pre-moist debridement cloths. So we've got lots of pictures of different types of wounds, and I'll go into those in a bit more detail. So hyperkeratosis, you all know what hyperkeratosis is. Those legs that you go and visit, or you pull down the dressing on somebody's leg and you think, oh dear, they haven't cleaned their leg for donkey's years. and you think, well, what am I going to do about it? I can't see what's going on under here. I don't know if there's ulcers under there, if they've got eczema, I don't know what's going on. So really you have to either soak this leg in a bucket of water for a couple of hours really and get the emollient on it and have a really good scrub. Who of us have time to do that nowadays? None of us, unfortunately. And really, if you don't treat it, it will just get progressively worse and worse and worse, and can lead to infection and skin breakdown and interfere with healing. And obviously, it makes the patient it makes them more isolated, and they don't want to bare their legs, and so it's very difficult, and you can lead to a cycle of social isolation and depression. So that's why it's vital to use on those. But we're going to have a look at a few more patients where we have used the cloths. So this is a young sickle cell chap, a different one actually, a different sickle cell man, who had a leg ulcer, and he would only allow, this is my colleague Kim, he would only allow her to use a gel dressing. And it actually created a lot of debris, and it created a very sort of wet, macerated wound. So, and he wouldn't let her touch the wound very much. So Kim gave him a cloth and said, okay, you do what you can to the wound and see what you can get off. And this is over stages, so this is over a number of weeks. And at first, he would just go around the edge quite gently, but then he found that he could actually get rid of some of the debris himself quite easily, and it gradually moved on, and you can see on the third photograph that there is lots of debris there, so he's managed to get quite a lot off, so he became much more involved with it and much more encouraged as it moved on, and you can see that the ulcer started healing as well, which was really encouraging for him, and he continues that. So he comes every week for his compression therapy, for his bandages. He looks after his leg with the cloths, and then the girls just put the bandages back on again. So that's a real success. This is an elderly gentleman who came to clinic with really dry, ulcerated legs. You can see the photos on the left, it's really dry and scaly, and really they don't look anything like they're going to heal, do they? It's going to be slow for them to heal. He was previously treated for several months following episodes of cellulitis by his practice nurse, and nothing really got any better, and it was just allowed to sort of continue. So when he came to our clinic, we found it very difficult to assess the wounds because they're so dry. We didn't know what was going on. So we cleaned them using the UCS wipes. What we tend to do is just put the wipe on the leg, let it really soak in to the leg itself over sort of 5-10 minutes while you're doing your notes or getting your dressings ready, chatting to the patient. And then it really softens it up, and then you can have a really good scrub and get it all off. So it took about 10 minutes to clean and remove all the dry skin, but after that you can see the photographs on the left. We could actually do a decent assessment. He actually had several small ulcers on his leg, and we were able to treat those with compression, and they healed relatively quickly. Whereas if we'd not bothered to get rid of that dry keratotic substance, then he'd still be trucking on with them now probably. Here we have an elderly lady who was awaiting a hip replacement, therefore she slept in the chair all the time. And this is one of these ladies that you just go in and you think, oh, her legs are just dripping everywhere, and it's just fills your heart with sorrow, really. So she couldn't go to bed, so she was sleeping in a chair. Her legs were just weeping, and she treated them with steroids herself, but she hadn't managed to get rid of the underlying cause, and so she was just continuing. The patient was being seen daily by the district nurses, so it was a real task for them to go in and do this every day, and every day the dressings would be really, really wet. So she came to one of our clinics where we got the cloths out and got rid of all that hyperkeratosis and all that non-viable tissue. And it actually, you can see, this is in just one session. It made a vast improvement to her legs. And we were able to reduce the dressing changes to twice a week after just doing that one thing and applying some compression. And she was actually discharged after 4 weeks from the district nurse's caseload. So if we hadn't done that, again, the district nurses would be going in and really wasting their time going in and in and in and in. Here we have a gentleman who's in his 90s with, you can see, very, very dry, scaly skin, bilateral edema. You can see his hosiery there on the floor. He was very good wearing his hosiery kit, but he hadn't been looking after his legs. So he'd been putting his hosiery on, that's commendable, but he hadn't been looking after his legs, and his legs has got into a mess, so he was running the risk of ulcerating again. So again, we softened up the skin using the wipes, and you can see the difference it made in one session. But it's just continuing that, and it was encouraging him to continue to use that treatment himself, and because it's so simple, then he could see that it worked really effectively. Then he kept on doing it, which meant that he didn't then ulcerate again. So that was successful too. This is one of my chaps who comes into clinic every week. Every week, before this really, his legs would get worse, they get better, they get worse, they get better. He'd always have lots of hyperkeratosis around the ulcers, which weren't ever big, but they would never really improve. So we got the wipes out, soaked them for a long time with sort of a doubled over cloth on top, and then really got to grips with it and got rid of lots of the dead tissue. what we also did was use it on the rest of his leg and debride the scaly skin that he had on the rest of his leg. And doing this on a weekly basis has made a vast improvement to his legs. He did have bilateral, lateral and medial ulcers on both legs. And now the lateral ones have both healed, the medial ones are nearly there, and his legs just look amazing, and he's so happy with the look of his legs. Here we've got a sloughy wound that's got some, sorry, excuse me, some dry necrotic tissue on the wound bed as well. And after just one treatment with the debridement wipes, we managed to actually see what we've got. And the wound itself, once we got rid of all that dead tissue, doesn't look too bad. It looks like it might actually go on to improve and heal. And we can actually see epithelial tissue there as well as granulation. Here we've got a sloughy wound bed that wasn't really going anywhere. So we used the wipes to really encourage the edge, and it was sort of debriding around the edge, and you can see that it looks much more healthy. Although we hadn't managed to get rid of all of the slough, the edge itself was looking more healthy, so and that in that way it would encourage migration of epithelial tissue over the top. We're nearly there, soon be lunchtime. And this is a sloughy wound bed. This is one of my patients. He's unfortunately gone into hospital now, so I'm not sure what's going on with him. But his wounds would always get really scaly. His wife would help to change the dressings. He was in juxtacures, and so they were able to care for the compression themselves. But his ulcers would always get really scaly and sloughy just within a week, even with her redressing. And so by using the wipes, we were able to get rid of the slough. And we still have to do this on a weekly basis, but we're able to get rid of the slough and the scale. And you can see the sort of little islets of epithelial tissue there that will all migrate across. So it's just being vigilant and just trying to continue that debridement, every time you see the patient, really. So that's a whistle-stop tour of debridement cloths. So now that you've seen the cloths and how simple they are to use and how effective they are, how many of you would now attempt debridement of wounds in your practice? Yes, more of you. Hooray. Okay, thank you for listening, and I hope that wasn't too speedy.